Good evening, viewers. In this lecture, we are going to cover the pathophysiology of heart failure and the treatment strategies with special emphasis on the pharmacological effects of digitalis. Stay tuned with me. Heart failure is a clinical syndrome characterized by inability of the part of the heart to pump enough blood and supply to the circulation. So it's more like living with a hurting heart. When we talk about heart failure, think of ventricular dysfunction. Now let's talk about heart failure in detail. This slide is looking very complicated, but just be with me. I will try to make it very easy for you and digestible as well. So this slide is projecting the sequence of events which follows when the heart fails to pump properly. So this illustration is showing the sequences or the consequences which occurs when the heart fails. So we have the low cardiac output when we have the forward failure, which is more common. Just recall from your pathology, we have another type of heart failure and we call it backward failure, which occurs because of the passive congestion of tissues. But as this is more common, forward failure, so let's focus our attention on forward failure. So left-sided heart failure is the more common beginning of it. The causes includes ischemic heart disease, hypertension, valvular heart disease, different forms of myocarditis, especially viral ones, and Coxsackie B virus is the most common, and so on and so forth. So we have low cardiac output in case of forward failure. So what happens after it, that the compensatory mechanisms or the neurohormonal mechanisms gets activated when we have decreased blood volume or blood pressure. So the reflexes sense it, the baroreceptor, the carotid bodies and the aortic bodies sense it and send signals to the brain, which stimulates the sympathetic activity. Sympathetic activity through its beta 1 receptor activation increases the contractility of the heart, whereas through alpha 1 receptor activation causes vasoconstriction of the vessels. Now if this is temporary, let's say for example if this is the initial phase of the shock which is reversible, then these attempts increase contractility and the increased vasoconstriction takes an attempt to restore the blood volume. But as this is a chronic process, this is heart failure, so this will further deteriorate the condition and this will contribute to increased afterload. Persistent afterload will further deteriorate the blood volume and decreases the cardiac output. So we have other hormonal mechanisms, compensatory mechanisms, which gets activated side by side to the neural mechanisms, and that includes renin, angiotensin, aldosterone system, which releases renin in the circulation, which stimulates the production of angiotensin 2 obviously from angiotensin 1 by involving enzyme, angiotensin converting enzyme. Angiotensin 2 is the second best vasoconstrictor of the body and further increases the afterload by vasoconstriction of the renal vasculature. By the way, what's the best number one top of the list vasoconstrictor of the body? Yes, ADH or vasopressin. So angiotensin 2, apart from second best vasoconstrictor of the body, it also stimulates the production of aldosterone, which causes salt and water retentions and causes edema, which further contributes to increase in the preload by the accumulation of blood by increasing the blood volume. The increase in the preload and the afterload causes the heart to remodel itself, and that is the adaptation process or remodeling. So in case of afterload, heart adopts concentric type of hypertrophy, in which the heart muscle cells multiplies and the room available for the ventricles to accommodate blood gets reduced. So with each diastole, less blood will be allowed to accommodate inside the ventricles, and with systole, less blood will be allowed to eject into the systemic circulation in this type of concentric hypertrophy. And what happens if the preload is increased in this type of condition, the heart causes dilated hypertrophy. The heart muscle stretches, and that stretch will temporarily try to compensate and will temporarily tries to increase the strength of contraction of the heart, but ultimately it will decompensate, meaning the strength of contraction will be reduced and it will further deteriorate the cardiac output and the condition will worsen. Alright. So in this slide you can see that we have agents available which can antagonize the effects of beta and alpha receptors on the heart and blood vessels, and can ultimately decreases the cardiac contractility and the vasoconstriction, and can decreases the afterload on the heart, and can stops or slows the progression of remodeling, that is the concentric type of hypertrophy in case of afterload. So these agents includes labetalol and carvedilol, which have the mixed alpha and beta blocking activities. So these agents, again, by blocking the beta 1 receptors on the heart, slows the contractility of the heart, and by blocking the alpha 1 receptors of the blood vessels, inhibits vasoconstriction. Again, inhibits vasoconstriction, and try to improve the afterload on the heart, try to reduce the afterload on the heart, and these agents improve survival as well. These agents includes labetalol and carvedilol. Now we also have agents available which have the effect on the renin, angiotensin, aldosterone pathways, and these are the agents known as very known agents, and these are the drug of choice for the treatment of heart failures, angiotensin converting enzyme inhibitors, and these includes captopril, enalapril, lisinopril, which are very effective agents for the treatment of heart failure. And these agents improve the afterload, reduces afterload, and these agents can also pushes blood from the left ventricle into the forward circulation very effectively. But if your patient is allergic to the use of ACE inhibitors, in case of cough or any other side effect angioedema, you can switch your patient to ARBs, angiotensin receptor blockers, which includes losartans, valsartans, candesartans. So these are the angiotensin receptor antagonist agents. Then you also have aldosterone antagonist available, spironolactone, which will try to decrease the salt and water retentions, and will try to improve the condition of edema. Now this slide is further elaborating the neurohormonal mechanisms, also known as compensatory mechanisms, which includes baroreceptor reflexes, renin, angiotensin, aldosterone system, and natriuretic peptides, which contributes to disease progression and worsening of the symptoms. This includes angiotensin 2, aldosterone, and the norepinephrine, which by causing increased contractility and vasoconstriction affects the afterload of the heart, further worsens it and causes concentric type of hypertrophy. On the other hand, aldosterone, angiotensin 2, which also causes vasoconstriction and increase in blood volume, which causes increase in the preload and causes dilated type of hypertrophy. So we have drugs available which have influences on the neurohormonal compensatory mechanisms. We have ACE inhibitor available, angiotensin converting enzyme inhibitor, which includes captopril, enalapril, lisinopril type of agents, which stops the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2, you know, is the second best vasoconstrictor of the body, and it is also a strong stimulator of aldosterone release, which is responsible for retention of salt in water and worsening of edema, which by increasing the blood volume further deteriorates the preload and causes remodeling, dilated type of remodeling. So angiotensin inhibitors, ACE inhibitors, basically cuts the production of angiotensin 2. If your patient is, you know, intolerant or having dry cough or other symptoms, angioedema, with the use of ACE inhibitor, experiences these side effects with the use of ACE inhibitors, then you can switch your patient to ARBs, angiotensin receptor blockers. These agents, ACE inhibitors, stops disease progression or worsening of the symptoms, worsening of the disease. Then we have agents available which have influences on the baroreceptor reflexes, on the sympathetic activity, and cuts the production of norepinephrine. I told you in my previous slides that we have mixed alpha and beta type of agents available, labetalol and carvedilol, which by, you know, blocking beta 1 receptors, it reduces contractility, and we have they have influences on alpha receptors as well, and by blocking the alpha 1 receptors, they actually reduces the vasoconstriction or blocks the vasoconstriction as well, and improves afterload. We have beta blockers available as well, cardioselective beta blockers, which are useful if the heart failure is basically caused by myocardial infarction. But as these agents, although they are useful, they actually decreases contractility, and they have you know, influences on the renin production as well. They cut the production of renin and ultimately control salt and water production by the aldosterone, controls the blood pressure. But before administering these agents, as these are the negative inotropic agents, you need to monitor the ejection fraction, which should not be less than 55%. Okay, so this is a classic illustration showing both of these types of remodeling which I just mentioned. As you can see on the left side, you have a normal heart, everything is normal in this, you know, illustration, in this projection. Just moving to the right side, we have the hypertrophied heart, and you can see this is a type of the concentric hypertrophy, commonly seen when you have persistent increased afterload. This is also known as diastolic heart failure. Moving forward, on the right side, we have the dilated heart, and this usually occurs when you have persistent increased preload. So hypertrophied heart and dilated heart, meaning concentric hypertrophy, and the dilated heart hypertrophy usually occurs at the same time.